a second case. This is a JM, this 52-year-old male. This gentleman is coming from Burundi. He's known to be diabetic for the past 20 years, and also he is known to be hypertensive for 10 years now. He has been on medication, the blood pressure has been controlled, and diabetes is well controlled as well. The main complaint that he presented to the hospital was the palpitation that has existed for many years. He's saying 15 years as of now. Sometimes when he gets the palpitation, he gets syncope. He has not developed any symptom that are suggesting heart failure, and the assessment showed that he don't have any symptoms that suggest he has thyroid dysfunction. He has normal cardiac anatomy and the function. The estimated ejection fraction is about 56%. The lesson ECG I'm going to show you, the Holter ECG as well, we are going to see it. So here we go. So basically what we are seeing here is a broad QRS complex. And what we are seeing here again, you find that there is, you see here, there's a delta. I mean, there's you see like a small slope that makes the QRS look big. This is what we call the delta wave. So because they are big with the presence of delta wave, we say this is a fully pre-excited QRS complex. Now this, because the patient is getting a symptom of palpitation, the tachycardias, now we are saying this is a Wolff-Parkinson syndrome. And so the next step is we want, because we are going to do EP and ablation in this patient, we need to localize where is this WPW actually is an accessory. It's not like AV and LT, where we find the AV node has got dual pathway. Here we are having a connection that is a connection that is connecting atrium and the ventricle. This is actually a pathway that is bypassing the AV node pathway. So we call it as accessory. And because the QRS complex is wider, then this is called the fully pre-excited QRS complex. And so I'm going to look where is it coming from. So the first trick is to focus on the lead V1 here. Now, when it is positive, I mean the site of connection is on the left, and when it is negative, you are thinking that the accessory is on the right. But look here, V1 and V2, they show early transition. Basically, this is telling us this patient has got a septal accessory pathway, and you find the lead 1 AVL, the lateral leads are positive. So the impulse is coming from the septum going toward the lateral wall, and you find that the inferior leads, lead 2 and 3 and lead 2, 3 are negative. That means the negativity tells that the impulse is going away from that site. So because this lead 2, lead 2, 3 and the AVF are negative, that means the wave of activation is going away from the inferior wall toward the lateral wall. So that is a septal accessory pathway.
The going away is posterior. This means that it is posterior. So it is yes. Posterior and septal, so it is a post-septal accessory pathway.
Yes. So yes. This patient was taken to the cath lab where actually the approach again was femoral vein on the right side. And when we inserted the catheters, again, as I oriented you the other time, that the whites represent the surface EKG. This is very important because it guides you to take all the basic information of the patient. And here again, you see there's a fully pre-excitation of the surface EKG.
This is the tachycardia. This is the tachycardia ECG.
Yeah. Yes.
Because, and you can see that it is getting narrow and as if completely normal. You have the limb leads up. This is limb lead 1. I think this is the inferior leads, V1 and V2. And at the moment we place the catheter inside the heart, the tachycardia started. So we were lucky because mapping during tachycardia is easier because it dissociates between the accessory pathway and the AV node. So this is AV reentrant tachycardia down the AV node and retrograde through the accessory pathway. And you can see this is why it is normalized. The ECG is normalized. And this is how we are going to look at the site of origin. In this case, the CS catheter was difficult to be introduced into the CS. That was the last case in the visit. And so we placed it in the right atrium and only placed the his in its position. And we started mapping by the ablation catheter. Go ahead, Gandhi.
Okay, so this is the ablation catheter with the intracardiac signals that you can see there, followed by the His catheter. And as a professor,
the CS is not placed correctly because
there is no
there was
signal
some
because
difficulty in the anatomy.
Yeah, anatomy. So you don't get any signal.
Yeah.
So the important thing here that we are seeing is that this patient is already in tachycardia, and what we find here is that this ventricular signal is followed by another signal very close there. We have two signals. That is, you have A and V. They are very close to each other. Almost they are fusing together. A and V.
Yes.
A and V. And this relationship is fixed every time. While okay. So we are saying this patient has got accessory pathway. That's why I find this fixed relationship.
Because we localized the accessory pathway in the post-receptor region, we went with the ablation catheter there. We tried to cannulate the CS, we could not. So we placed the catheter into the right atrium, but the His was in the right ventricle. We started to map during tachycardia with the ablation catheter to get the shortest VA time. As you can see with the QRS complex, this is the V with the A and the A coming after, which is very, very close. And sometimes you can see an accessory pathway potential. Continue, Randy.
So yes, as the professor said, we are mapping during this tachycardia. You find he was looking at the shortest VA time. And this time we started to ablate. As you can see, there's these changes of the ablation catheter. So because this patient was in tachycardia, so the tachycardia actually was stopped by burst. I mean, it was a straight pacing with the cycle length that was greater than the tachycardia cycle length. This was 100 beats per minute. So we went to only about 200 beats per minute that terminated this tachycardia before ablation started. So this slide is showing to you that this patient.
I want you to show us the successful ablation site because this is pacing post ablation.
I'm sorry, I did not take the scene from this for this patient.
Not cine, the intracardiac.
Yeah. So the intracardiac, I can show you is this.
Okay,
one.
This is
after ablation.
Yeah. Now, what you show us now is that we ablated, we started ablating during the tachycardia, and you can see immediately in the last beat, termination in the retrograde limb, and then normalization of the ECG. As you can see here, completely normal ECG with the one burst of ablation at the correct site. And you can see here, the blue catheter is the His catheter, AHV. The yellow catheter is the ablation, and the green one is the CS catheter, but placed into the right atrium. Now you can show us the V pacing after ablation, Gandhi.
Okay, V pacing after ablation is this one. So here, carefully when looking at it, what you find, for example, this is actually is ventricular. You are pacing from the His that is actually in the right ventricle. That's why you get wide QRS complex. So tracing from there, you find this V that's followed by A. This V that's not followed by anything. Then you have V there. So there is a VA dissociation that you are no longer conducting from the ventricle to atrium. That the accessory is successful. Accessory pathway now successfully ablated.
Yes. So this shows you that you normalize the ECG after ablation during tachycardia, and then you have to confirm that there is no conduction of the accessory pathway by pacing the ventricle and looking at any atrial conduction. As you can see in this beautiful tracing, Dr. Gandhi is doing V pacing, and the green sharp signals, The green sharp signals, these are the atrial signals. They are not following this ventricular pacing, meaning that the accessory pathway is no longer present, neither in the anterograde limb nor in the retrograde limb. Yes, continue, Gandhi.
So
show us the ECG after ablation.
Okay, so after successful ablation, what we did was a program with simulation to confirm that this has terminated completely. So we did with the atropine that actually showed the good conduction anterograde and also enhanced retrograde, but no tachycardia this time was induced. So finally, we had these ECGs that are put together. This before ablation, which is fully pre-excited, and you see very normal narrow QRS, ECG with P waves and the QRS, very beautiful, successful ablation.
I want to add something that look at the inferior leads, which showed the negative delta. Now you can see T wave inversion. This is, they call it memory of the accessory pathway repolarization, which stays for some time, like 1 month or so, with the memory of repolarization from the accessory pathway. So afterwards, if you get this patient after 1 month, you'll find that his T wave in the inferior leads will be completely upright, not inverted. Thank you, Dr. Gandhi. And now we can open for discussion. Please, anyone want questions?
Thank you.
Thank you very much, Gandhi. That was an excellent one. Thank you very much.